Welcome to the Deep Dive. Today we are strapping in for a really critical exploration of the body's ultimate command center, the hypothalamic pituitary axis.
It really is the central switchboard, isn't it?
Yeah.
You have these two tiny glands, the hypothalamus and the pituitary. The hypothalamus is sort of the conductor telling the pituitary, the maestro, which hormones to release or, hold back.
And that balances everything. It governs how tall you grow, how your body manages water, the whole system.
Right. It's all about systemic homeostasis.
So our mission today is to give you a critical shortcut. We're distilling the most important pharmacological nuggets for treating disorders of these glands. We're talking hormone replacements, some surprising agonists, and of course, the crucial antagonists you really need to know.
And this is essential because these drugs are so powerful. You're not just treating a localized infection, you're fundamentally manipulating the feedback loops that run the entire body. If you mismanage it, you're looking at systemic trouble.
Okay, so let's nail down the key terms fast. When the pituitary, especially with growth hormone, goes wrong, the results are, well, they're dramatic. If you have a GH deficiency in a child, we see dwarfism.
Right. And if you have an excess of it before the growth plates, the epiphyses close up, that's gigantism.
And if that same excess happens later in life after they've fused,
Then you get acromegaly. You see this thickening of bones in the face, the hands, the feet, but no more height. We also have hypopituitarism, which is more of a general lack of pituitary function that causes a whole cascade of problems downstream.
and one more, a crucial one for fluid balance, diabetes insipidus, DI.
Yes. This is where your body lacks antidiuretic hormone, or ADH, and the result is just copious amounts of very dilute glucose-free urine. It's a huge dehydration risk.
But because the effects are so pervasive, growth, metabolism, water balance, nursing care, it's everything.
You can't overstate it. Monitoring electrolytes, tracking blood sugar, making sure the administration technique is perfect, all of it is absolutely non-negotiable.
Let's start right there with the non-negotiables. Safety across the lifespan. I imagine the therapy for these conditions looks very different for different age groups.
Oh, completely. You have to customize your monitoring. For children, the focus is squarely on safe, measured growth. And it's not enough to just watch a height chart.
No, you've got to look deeper.
Exactly. You're monitoring metabolism, which means frequent blood sugar checks. But the really unique safety check here is the periodic radiograph of the long bones.
That's the ultimate safety stop sign, isn't it?
It is. If those radiographs show that the long bone epiphyses are closing, the GH therapy has to be stopped immediately. Otherwise, you risk deformities or other complications down the line.
And for a drug like desmopressin for DI in a child.
An adult has to be responsible. A reliable adult must manage the whole protocol, from mixing to dosing, no question.
Okay, so then for adults, the focus shifts more to, what, administration?
Mastery of administration, yeah. Many of these are injectables or nasal sprays, so adults need to master the preparation, the storage, and especially injection site rotation.
Because if you don't rotate, the tissue gets damaged.
And then drug absorption becomes completely unreliable. The dose you think you're giving isn't the dose the body is getting. For older adults who are already more susceptible to fluid imbalances, we add another layer of scrutiny. You have to frequently check their nasal mucous membranes.
That seems like such a small detail, but I'm guessing it's critical. Why the nose?
Because if those membranes are dehydrated or have ulcerations, it can severely mess with absorption of any nasal sprays. The patient might not get the full dose, or they could get too much if it absorbs erratically. It's a huge variable.
And a final blanket warning.
Universal caution. These powerful hormonal drugs are pretty much always contraindicated during pregnancy and lactation. The risk of severe adverse effects to the fetus or neonate is just too high.
All right, let's move up the chain to the conductor itself, the hypothalamus. It releases factors that either stimulate the pituitary, like GnRH or GnRH, or inhibit it, like somatostatin.
And what's so fascinating is that the drugs we have often do much more than simple replacement. They're used for really complex things: diagnostics, cancer treatment, even fertility regulation.
Let's jump into the most counterintuitive example, the GnRH agonists. We're using Leuprolide as our prototype here.
Right, so drugs like goserelin, neferilin, Leuprolide, they are agonists. They mimic and stimulate the hormone, but we use them to shut the system down.
Okay, let's break that down. How does a stimulator become an inhibitor?
This is the paradoxical blocking effect. Leuprolide is super potent, so
Okay.
when you first give it, you get this huge initial burst of FSH and LH, a big spike.
So a temporary flare-up of symptoms?
Exactly. But if you keep giving it, that constant non-pulsable stimulation is like sensory overload for the pituitary receptors, they eventually just get desensitized and stop listening.
So you're basically exhausting the system into submission.
You are. It leads to a profound inhibition of gonadotropin secretion. So you use a strong stimulator to cause long-term suppression, which is why Leuprolide is used for things like advanced prostatic cancer or endometriosis conditions where you want low sex hormone levels.
Interesting. And there's also a unique one, tesamorelin.
Yeah, that's a GnRH analog. It's used for a very specific purpose, to treat the excess abdominal fat, the lipodystrophy, that you can see in HIV-infected patients, of very targeted use.
And on the flip side, the antagonists, like cetrorelix, they just straight up block the GnRH effects.
Right. And for all of these, the adverse effects are exactly what you'd expect. The initial agonist burst can cause flushing and fluid retention, but the long-term suppression leads to low sex hormone symptoms, like loss of energy or lack of menstruation.
A quick note on delivery. Some of these are long-acting shots, right?
Yes, many are slow-release depot forms that last for weeks. So an administration error has long consequences. And if you're using a nasal form like neferilin, remember that rhinitis, just a simple stuffy nose, can totally change how much drug gets absorbed.
Okay, so from the conductor to the maestro, let's pivot to the anterior pituitary and focus on growth hormone. The main replacement therapy is somatropin.
Right, somatropin is our GH agonist prototype. It's used for GH deficiency dwarfism in kids or somatotropin deficiency syndrome in adults.
And there's some important history here, a real safety point.
Oh, yeah. We thankfully moved on decades ago from using costly, sometimes contaminated cadaver-extracted GH. That stuff could cause life-threatening reactions. Now we have the much safer, reliable rDNA-produced somatropin.
So when you're administering this, especially to kids, the monitoring is intense. What are the key things families need to be reporting?
Well, any lack of expected growth, obviously, but also any sign of glucose intolerance. We're talking excessive thirst, hunger. GH can push blood sugar up. And again, those periodic long bone radiographs are mandatory. Epiphysis close, treatment stops.
And the text mentions an innovation in delivery, the cool.click2 system.
Yes. It's this neon-colored, needle-free device for a child facing daily injections for years, using a system that turns the medicine into a fine mist and eases that discomfort. That's a huge improvement in quality of life.
There's also a quick mention of an alternate therapy, mecasermin.
Right, that's an IGF-1 analog for patients who don't respond to GH itself. And the absolute #1 safety rule for mecasermin is that the patient must eat immediately after administration. The risk of severe hypoglycemia is that profound.
Okay, let's flip the switch. What about the opposite problem, GH excess causing gigantism or acromegaly?
For patients who can't have surgery or radiation, we turn to GH antagonists. Our prototype here is bromocriptine mesylate.
And the drug classes include dopamine agonists like bromocriptine and what else?
And the synthetic somatostatin analogs like octreotide and lanreotide.
Bromocriptine's mechanism is another one of those paradoxes, isn't it?
It is. It's a dopamine agonist. It stimulates dopamine receptors. But in acromegaly, that stimulation actually inhibits GH secretion. It does it by telling the hypothalamus to release more somatostatin, which is the body's natural off switch for GH.
So you're using the body's own brake system. Now, what about nursing safety? The somatostatin analogs, octreotide and lanreotide, have a really specific critical risk.
A huge one. They are strongly associated with developing acute cholecystitis, gallstones, or pancreatitis.
That is a high-stakes fact. So what's the mandatory monitoring for that?
Every single patient starting on octreotide or lanreotide must have a baseline ultrasound of their gallbladder. And then they need periodic repeat ultrasounds to watch for gallstone formation. It is a crucial specific safety check.
And bromocriptine.
That's more of a central nervous system drug, so the risks are different. Primarily drowsiness and postural hypotension.
All right, final stop. The posterior pituitary. It stores ADH and oxytocin. We're focusing on ADH.
The goal here is simple. Manage water balance. If you have diabetes insipidus, or DI, you have too little ADH. You're losing tons of water. So we treat with the synthetic ADH analog, desmopressin, or DDAVP.
And it just tells the kidneys to reabsorb water.
Exactly. But if the patient has the opposite problem, SIADH syndrome of inappropriate ADH, they're retaining too much water, so we need to get rid of it.
For that, you use blockers.
Correct. Vasopressin blockers like conivaptan or tolvaptan, they block the ADH receptors, forcing the kidneys to excrete water, which helps raise serum sodium levels.
But these aren't drugs you just send a patient home with, right?
Absolutely not. They have to be given under close hospital supervision. You're shifting fluid and electrolytes so rapidly.
Yeah.
The risk of polyuria, blood pressure swings, and dangerous electrolyte changes is just too high.
This brings us to a really crucial teaching moment, that scenario about the patient, BT. It really highlights the importance of technique for something like desmopressin nasal spray.
Oh, the BT case is classic. She was a veteran user, had been on it for years, but she forgot one simple instruction. She started tilting her head back and over-squeezing the bottle.
Thinking more is better.
She thought she was maximizing the dose, but what she was really getting was maximal systemic absorption. The drug was going way beyond the nose.
So that systemic overdose of ADH basically tricked her body into thinking it was severely dehydrated when it wasn't.
Precisely. And that caused acute adverse effects, severe GI cramping, headaches, even nasal ulcerations. And of course, the ulcerations just made the absorption problem even worse. The nurse had to stop the drug and reteach the whole thing from scratch.
So let's be crystal clear. What is the correct technique?
You sit upright, you firmly close one nostril, hold the bottle upright about 1.5 inches into the open nostril, give a firm single squeeze, and this is the most important part, do not tilt your head back. You want localized absorption, not fluid dripping down your throat.
And the ultimate danger we're trying to prevent with all this is water intoxication.
Yes. That's when the patient retains too much water, their electrolytes get diluted, and you start seeing signs like drowsiness, headache, and potentially seizures or even a coma.
And a final drug interaction alert.
If desmopressin is combined with certain other drugs, like carbamazepine or chloropropamide, that risk of water intoxication goes way up. You have to check that profile carefully.
What a dense dive.
Right.
We've covered the hypothalamic regulators like those paradoxical GnRH analogues, the anterior pituitary with GH drugs, and the posterior pituitary agents balancing water.
And the overriding truth through all of it is that these drugs have systemic ripple effects. The nurse has to be a detective, constantly monitoring thyroid function, glucose tolerance, fluid, and electrolytes. And as we saw with BT, sometimes the most basic teaching proper administration technique is the only thing standing between the patient and a life-threatening event like water intoxication.
That is the ultimate takeaway. We saw how a patient forgot a simple instruction after years of routine, and it led to a major complication. So considering these incredibly potent hormonal agents, how often do you think those routine, seemingly minor safety checks need to be reviewed, even for patients who feel like experts in their own chronic care? Something to mull over.
Always be reviewing.
That's it for this deep dive. Thank you for joining us. We'll see you next time.